Good afternoon, my dear friends. Today I am going to tell you just the overview of the FUE. What is FUE, how it is being done, what are the instruments which are required for. This is more or less going to be a basic lecture. I am not going to go in the details of the instruments and the procedure in detail. So what is the goal of the hair restoration? The goal of hair restorations are three: the medication, mechanics and artistry. Medication to restore the weak hair and to prevent the ongoing hair loss. The reason being, when you are doing the hair transplant, you are not replacing all the number of hair follicles which has been lost. So there is a gap between the demand and the supply. Means the recipient area needs lot of hair follicles, but the donor area has got the limitation. So there is a need of medical treatment so that we can restore the weak hair and we can prevent the ongoing hair loss. The mechanics, we should use all the technique and technology to have the maximum survival and the growth of implanted hair. And the last but very important is the artistry, for which the patient has come to you. There is the framing of the face, means natural lining of the hair line, incorporating all the important landmarks. The basic thing is, why do we need hair transplant? How does it is going to affect your aesthetic? Is the reason is, we all know the beauty lies in the mathematics. All body parts are in equal proportion. If that proportion is disturbed, then it affects or it compromises the aesthetics. Similarly, we know the face has got the 3 times than the length of the nose, means the 1/3 is this, 1/3 is this, and the 1/3 is this. When the hairline recedes, then the frontal area becomes large in size and the proportion is disturbed. That is why we need the hair, and the hairline is the border between the face and the scalp. Now the causes of hair loss are many, but I am going to tell only the basic cause, that is the male, mainly the androgen and the genetic. So genetically predisposed hair follicles fall under the effect of the male hormone, and for the female there is a definite linkage between, there is a definite cause of the genetic and also the androgens, but there are a few cases in which the androgen has not been correlated with the hair loss. So sometimes we call it as androgen dependent hair loss in the female and non-androgen dependent or androgen non-dependent cause of the hair loss. Then the other which are common is the nutritional deficiency. In female, most common is the ferritin deficiency. Then what is the medical treatment? US FDA has approved the 5% minoxidil application twice a day. It has to be applied over the scalp twice a day, and the finasteride 1 milligram every day. Even the low doses of finasteride also work, and there are studies which says that 0.2 milligram every day of finasterides also affect. Personally, I give twice or thrice a week or alternate day finasteride I give to the male. Then the female patient, the minoxidil 5% once a day is the basic treatment for the female endogenetic alopecia and the correction of all the nutritional deficiency, including the ferritin. Then now we come to the FUE, Follicular Unit Extraction. Previously it used to be called as extraction, but now the ISHRS has redefined the definition or the abbreviation of FUE is Follicular Unit Excision. The excision is the correct term because the excision indicates the surgery, and this can only be done by the allopathic trained qualified physician or the surgeon. The definition of FUE is, as per the ISHRS, is the method of isolating and harvesting an individual follicular unit from the donor area by manual or motorized punch or by the robotic devices. Unfortunately, this method FUE has become popular not because of its high quality technique or the modern, but because of some myth related with, and it is less invasive. It's not so. If there is a scarless, it's not so, it is wrong, and painless, it is also wrong. But there is only one thing which is right, is that there is no suture is needed after completion of this surgery. The instruments we need is the manual devices or the motorized devices or modern devices or the advanced devices like vacuum assisted, robotic devices are there. Then the punch we need, and I am not going into the detail, but broadly we say sharp or the dull punch or serrated punch, and many other type of flared punch, flat punch. There are many other punches are there. Now these are the various devices. This is the hand manual punch, then this is the motorized, the most simple one. What I use, this is the hand piece. In this hand piece you can use any size of the punch, but if we use these hand pieces, they get spoiled because we are using them continuously and there is a constant saline is there, so they get jammed and they get spoiled and you need to replace them early. This is the safe by Dr. Harris. This is the coal isolation device, this is the new graft, and this is the robotic. What I use is, this is the machine which I'll advocate you, that's why I have given the name of the company and also the complete detail. This is a very good machine. Another simple most we have been using is the maxillofacial surgery for we have been using. This is another, and this is the coal punch, ultra sharp serrated punch which I use. And this, as I explained you, this is a very nice handpiece which is economical also and doesn't spoil so quickly. These are the various punches. They are the two main classification. One is the dull punch and another is the sharp punch, and they come from various sizes starting from 0.7 to 1 mm. Of course 1.1 and 1.2 mm do they come, but the micro punch definition is 1 mm or less than punch is called as that. Then this is the dull punch, this is serrated punch, this is serrated window punch, this is dull Higgs punch which dissect also given by the Harris. This is a window is there in this, there is a slit in this. This slit is being used for long hair harvesting, and this is a flared punch. This is also a good punch. I have used it, especially I have used for the abdomen cases. These are the various implanters. My message to the new surgeons is that if they start habit of using the implanter, in long run this will be good. So various types of implanters are there. Then this is the operating table. We all are the surgeon. We can use the same operating table or we can use the dental one. I use this, especially thigh massage chair. You can get on the net, or you have to little bit try for this. In this you can change the position of the head. Then I come straight forward to the graft injury. Many times we see we are extracting and we forget what quality of graft we are extracting. The outcome of your implantation or the hair transplant depend on the quality of the hair graft you take out and implant them, and how much injury you are producing while extracting them and while implanting. That is extremely important. When times you know only two injury means the transection. Transection can be partial transection, like you see that there is a partial transection, only one follicle out of two has been cut, but here you see the complete transection in which both the follicle has been cut. Then the other injuries like the fracture of the shaft, then the bulb injury, desheathing injury, then there is a bulb injury to the bulb only. These are the various injury which can be inflicted during the extraction and also the implantation, and you must take care of it. Even the slightest trauma created to the bulb or the bulge area may influence the thickness of your hair fiber. Then comes the safe donor area. This has been described by the Cole. He has given the 8 major area and few 6 the minor area, which is in the nape of just above the nape of the neck. You can read in the detail, but mind it, never extend your harvesting beyond the safe area, otherwise you will lose them. As it is commonly said that Sehwag has lost, probably the hair follicle were harvested from the unsafe area. An enthusiastic surgeon does this. Then the donor area evaluation is another important. It's you have to see the donor area for the diffuse pattern hair loss means DUPA, diffuse unpatterned hair loss, in which the telogen hairs are more than the 20% or more number of villus hair are there, or there is a diffuse thinning or diffuse decrease in the density including the safe donor area, that is called a diffuse unpatterned hair loss. You must see that donor density, if it is less than 60 graph per square centimeter, this is not a good donor area. Then also you see the curl, if their curl is high, then their high transaction rate is there. And scarring, if extensive scarring, then there will be high transaction and it will be difficult to harvest. Then how to train yourself? This I have put for the learners who wants to start it. I have developed a training module. This has been published also. The transaction should be reduced and the goal should be the transaction should be 0. How to achieve? I have developed a scoring technique. This has been published in Journal of Cutaneous and Aesthetic Surgery, in which the scoring technique you need magnification. I advise 4.5 should be the optimal and you should use on that. Firm pen holding, we all are plastic surgeon, we know how to hold a punch or how to hold a knife, and stabilize your hand, concentrate on the eject angle of the hair, then score the skin by the punch. I'll show you the video. Keep hair in the center of the punch and punch parallel to the hair, and practice goal should be, if you score 10, it should be exactly 10. And how to analyze this your scoring is, if you are parallel to it and B will be deeper to the A, and you will create this mark. If you are not perpendicular to it, then A and B depth will be the same, and if it is reverse, then A will be deeper, means in these two conditions you are going to transact, but in this condition you are not going to transact. Now you see how it is going to work. See, this is the scoring. You just score with your punch the epidermis, and you see these are the marks has been created over here. Now how to analyze? You can see here it is eccentric, and the deep is the A part is deeper than the B part. Here you see the hair is in the center of this score and the B is deeper than A. So you know, if you extract this, you would have done the transaction, but if you extract this, the transaction would not have taken place. So before doing the real extraction, you know that this would have been transacted or this would not have been transacted. That's how I myself practice it, and my wife Dr. Seema has also practiced on this scoring module, and we learned that our today transaction rate is less than the 2%, and most of the time it is less than 1% also. And the depth control is another crucial part to prevent the transaction. This is how you need to apply the guard over here. It is self-explanatory. You need to cut. The control should be just above the bulb of the hair follicle, so you don't go up to that level, and you can see the guard has been applied. This guard will prevent you by going the deeper and transecting the follicle. The stability technique are developed as we do swimming or when we learn the cycling. The firm grip, then the land means touch your punch to the skin, then start your motor, rotate, go in, stop and come out. So in this, if you do it, then if your punch is moving, means your motor is in on model, and when you are landing to the scalp skin, there is a some wavy movement. To prevent that, I tell you, first land, rotate, go in, stop and come out. This will give you the stability. Now you see, you can see this, how it is going to work. This is the safe donor area which I have marked. We 2%, me and Dr. Seema, my wife, do together. We divide half of the area. Now you see, this is in one go. We are going. I have just parallel, this is in the slow speed, stabilize the skin, tense the skin, and the extraction means scoring as well as the removal by the two technicians are there. Me and Dr. Seema both are doing, and our assistant are removing. Removal is very important because it should be done by the two hands to prevent the avulsion injury. Then the complications. Don't think that FUE is complication free or any surgery is complication free. There can be donor depletion, there is extensive scarring, and the transection. Donor depletion is because of the over harvesting. Scarring is also because of the use of the inferior quality of punch, large size of punch, extracting two together too close to one another, and transection because of the faulting learning technique. The scarring in FUE is, if we calculate as per the pi r square formula, then if you want to extract the 100 grafts from 10 centimeter long strip, then there will be 10 centimeter long scar, while if you 100 FUE, then it will be 34 centimeter scar will be there. So the volume of scar in FUE per se is more, but there is no linear cut. That is the only thing. Another thing is, if your angle of extraction is too flat, then the scar or the hole will be the bigger one. But if you alter slightly the angle, pull the skin up so the angle opens up, and when you penetrate inside, then the angle will be more obtuse, and the size of the hole or the scar will be less. How much graft can be extracted? That is also very important. I tell you, in one go, 20% of the total density is the safe limit, and the total amount in multiple stitches should not be more than the 50%. If more than the 50% is extracted, is going to reflect in the form of thinning or low density in the donor area. Then now we come to the body hair transplant, which seems to be the major advantage of the FUE. We have got the numerous 5 millions of hair follicle all over the body, and out of them at the adult stage, many of them are in terminal stage. You can see this hairy man, so you have abundant donor area. Now, how to calculate the number of requirements of the graft? It is a very simple principle I have given is the forefinger. We all know that forefinger is equivalent to the length of the nose, and we can divide that bald or balding area, front forefinger, middle forefinger, and the back side, the crown area forefinger. A forefinger area is 100 square centimeter, bald or balding area is a 300 square centimeter. If you want to give 30 graft per square centimeter, then we need 9,000 graft total to cover, and this much graft is not available, but at least 7,000 is needed. So scalp we can extract 5 to 6,000, and will be lacking 1 to 2,000 or 3,000 follicle, which we can cover the body only. The body hair got different characteristic than the scalp. I'll just enumerate one by growth. Body hair is slower to grow, while the scalp grow much faster. Similarly, thickness of hair, scalp is better except the beard, and rest of the body hair are thinner. The recipient side influence is there. The Tommy Huang concept, he says after implantation from one part to the another body part, the thickness remains the same, but there will be alteration in the length. Then the follicular unit, mostly the body hair are single. Of course, there can be 2 and 3 sometimes. Exit angle is more acute, and depth they lies more superficially, so more chance of transection and difficult removal is there. The variation in the length of the cycle, the longest anagen phase is of the scalp and the beard, shortest is in the eyebrows, and the shortest telogen is the beard. That is the region the beard grows much faster. Then the variation in the density, then we go on the variation in the hair cycle. Anagens are scalp 90% are anagen, 10% are in telogen, beard 70% in anagen, 30% are in telogen, chest are 30% in anagen only. This is very important thing to know. This is the hair cycle. I am not Then who is a good candidate for the BHT? Not every candidate is good for the BHT, means harvesting. The poor availability, thin, and patient is not willing. These are the cases in which you cannot harvest from the body area. Robert too has described a torso index for the chest hair. He has included the density, texture, number of hair per follicular unit, surface area and hair length, and accordingly he calculated. TDI, if less than 4, then they are not good candidate. More than 7, they are the good candidate. Like this, if you see, the TDI score is 9. Then the challenges with the body hair harvesting, it needs a long learning curve. The reasons are there is acute angle, more superficial sitting follicles in the collagenous dermis, unlike the scalp hair which floats in the fat. The absent bony support and the bulky soft tissue. Some body hair are thin, hence do not have a strong shaft to facilitate easy extraction. The greatly variable direction and pattern of the body hair. It is difficult positions, and the anesthesia and more telogenous hair are there. This is the, I think this should be the video. Then the most commonly used is the beard, then the chest, abdomen, and then the extremities. I have no experience of using the extremities here. The preoperative preparation, it is better if you advise your patient to use the minoxidil few weeks, preferably 6 weeks prior to the harvesting. This is the shaving for the beard 3 days before shaving, and the chest 10 to 15 days, so that when the hair grow, only the anagen hair grow. Then the anesthesia, I use Prilox gel 1 hour to 30 minutes before. This is the way how I apply it. Then there is a film over this, and to reduce pain we use the ice pack, vibrator, thinnest bore needle, and injecting very slowly. Also I use the IV midazolam, and tumescence anesthesia we tell is the better, less dose is required, and gives constant homogeneous anesthesia in that part. Then the beard area, which area you need to take, which not to take. The red mark area you should not, perioral area you should avoid. 4 means the sideburn area is a relative contraindication, rest you can take. Preferably is your shadow area is the most preferred area from where you should harvest. This is the beard hair harvesting. As I told you, me and Dr. Sima both harvest together. The advantage is the harvesting time is just become 50%, and the operative time becomes 50%, because we do the mega session, basically mega session or giga session, in which we harvest 3,000 or more than 3,000 graft in a day, because we use the dual team tech. Here again you see the 2 forceps removal should be there. Don't remove by using the single follicle, single forceps. These are the beard hair. You can see how beautiful they look, and after the extraction you see these are the marks, very tiny marks. I always keep them in the plasma, so they are covered with the 3D fibrin scaffold and they remain safe. This is immediately after, this is after few days of harvesting. This you can see on both sides, left and right side. After few days, this is the chest area. We all plastic surgeon, we know from the external region we should not create any wound. And then how glide skin over the angle, as I told you, you can alter the angle by moving the skin over the bony prominence. The skin should be tense and you should focus. Now you see how the chest hair are being harvested. The skin should be tense in between the 2 fingers, or you can take the help from your assistant. Target your hair, see the angle, centralization, center is there or not. Sometimes it is better the hair is little eccentric, because you center not the hair, you center the epidermal blush. I'll show you in the next slide. Gently you do it. The prerequisite is the tense skin, stress the skin between the 2 fingers. Go gently, follow the angle. Again 2 forceps concept while removing the scored follicle. They come very easily. If they are not coming, then you can use the another one. You see, it was difficult, so I used the 2 finger here, 2 forceps here. It was coming gradually, so just pulled it very, very gently. They are very delicate, very delicate. There can be desheathing, there can be fracture, there can be injury to the bulb also. So you need to be careful that you don't injure any part of the hair follicle. This is all how they are coming. This is simultaneous extraction and implantation. We 2 persons are doing extraction and 1 person is doing the implantation. This is a patient who come from US just for the body hair transplant to us. Now proper centering, where to focus? This is the epidermal blush. It should be centered rather than the hair. If you can see this, and for that you need at least 4x magnification, certainly you will not transect. I am telling you, this is the most key for the success to reduce the transection. Then the estimate time should be reduced. Do simultaneous implantation and harvesting in small multiple session and implantation. Then the no touch to root technique is the important aspect to prevent injury to the hair bulb, which is very crucial. You see, we are not touching here the follicle at all. We are holding hair follicle by that small shaft of the hair. So nowhere follicle is being touched. This is the no touch to root technique. And 2 persons, me and Dr. Seema, both are doing the implantation here. This is no touch to root technique. Now the planning of combination. Now I tell you how to do the combination. This paper has again been published in international forum. You can see that article. I use body hair along with the scalp hair to cover the deficit of the required number and to enhance the visual density, especially in grade 7 and grade 4. I have given the complete planning. I am not going in the detail of it because it needs more detailed elaboration, but just to give a glimpse of it, how these are being used. On day 1 I use the scalp and day 2 I do use the beard in between. This is a planning where I put the beard and where I put the scalp. This is the, I am just skipping. Then the complication of body hair, be careful about the total amount of anesthesia, ingrown hair or the cyst, hypo or hyperpigmentation, and temporary facial paralysis or paresis can be there. We all know about the facial nerve. These are the few results you can see with which I did the combination of beard and the chest. This is another case. This sort of density you can get along with the combination of body hair and the scalp hair. Similarly, these are the another cases. The details are given here for every case. 5,119 scalp and beard. This is another 3017 graft beard and the chest. This is another total 3209. Even in the grade 4 I also use the beard graft. This is the grade 7, 2 days we have done for him. He needs more. This is another 4,900 graft. This is another case 4,500 graft we did in this case. You can see the fullness here. This is another grade 7 in which he was not having the sufficient scalp hair. We did 4 days, 2 plus 2 days, scalp, beard, chest and abdomen, and we harvested almost, no, I think this figure is not right here. There is some mistake here. Almost 6,700 something grafts were put in this case. I'll correct it. I'm sorry for this. And then another case is, this is another patient in which we did it. This is another case. This is another case. Thank you very much. So my end message is, FU has a long learning curve. You should learn it properly and then start with the short session. It is better to start with the manual one, then you can go on the motorized one. Do the short session and don't do the over harvesting. Donor area examination.